Welcome, everyone. Um, Welcome to today's Schwartz Center Compassion Action webinar, a fireside chat with Steve Trzeciak, Leading with Compassion. Thank you for joining us. I'm Julie Collier, Senior Director of Programs here at the Schwartz Center. As many of you know, we are a Boston-based nonprofit organization established in 1995 to advance compassion in healthcare. Our vision at the Schwartz Center is that everyone who provides and receives healthcare experiences compassion. Before we begin, I'd like to share a few details about what you can expect. Please note that the program will last 60 minutes with an opportunity for questions in the last 15 or 20 minutes. Feel free to enter your questions in the Q&A pane throughout the discussion. I'd also like to acknowledge with gratitude that this Compassion in Action webinar series has been funded in part by a generous donation made in memory of Julian and Eunice Cohen. With that, I'll hand it over to Dr. Beth Lown, Associate Professor of Medicine at Harvard Medical School and Chief Medical Officer of the Schwartz Center for Compassionate Healthcare. And I know she's excited to get this conversation started.
Thank you, Julie, and thank you everyone for joining us today. We are joined by Dr. Steve Trzeciak. Dr. Trzeciak is Chairman and Chief of the Department of Medicine and Medical Director of the Adult Health Institute at Cooper University Healthcare. He is Professor of Medicine at Cooper Medical School of Rowan University and author of two important books, Compassionomics, the revolutionary scientific evidence that caring makes a difference, and The Wonder Drug, 7 scientifically proven ways that serving others is the best medicine for yourself. So Steve, welcome.
Thank you so much, Beth. It's an honor to be with you again, and I look forward to the conversation.
Yeah, we've been really excited and looking forward to it as well. So I'm going to dive right in. You know, you began your first book about Compassionomics talking about a compassion crisis. So we were wondering if there was a story that brought this home to you in your own work or an experience that you might want to share with the audience. And if you could just unmute yourself and we'll get this talk going.
Sure. Well, more than a story or an anecdote, what I find really compelling is data. And I think that we should be, our expectation should be that we have the same appetite for data and expectations for data in this space as in any other. And so rather than examining compassion through a moral, ethical lens or an emotional or sentimental lens, my position, as you know, from our previous conversations, is that I believe we should examine compassion through the lens of science. So it's really the data that I find compelling. And there are data for a compassion crisis. And you might say that, or someone might say that there's evidence for a compassion crisis in society in general. And there are data for that. So Sarah Conrath and colleagues have found from the University of Michigan, a systematic review and meta-analysis, which has found that empathy among college-age students has been declining over the past 2 decades, and the speed of that decline is accelerating over time. Accordingly, related to this, a study from the Harvard Graduate School of Education found that in a study of 10,000 youth in the U.S., so these are middle school and high school students, fully 80% of our youth believe that their parents value their achievements and their accolades more than they value their kids' kindness for others. And in a striking Pew Research study from just a few years back, fully 1/3 of Americans endorse that they don't consider compassion for others to be among their core values that describes them well. And so that's in society broadly. And many people have been experiencing this in other ways as well. But what about healthcare? Healthcare is supposed to be different. Well, you and your colleagues published a study in Health Affairs years back that nearly half of Americans believe not only that our healthcare system is not compassionate, but that our healthcare providers are not compassionate either. And in my domain, critical care, a Johns Hopkins study found that 74% of interactions between the ICU team and patients and families in the ICU is devoid of compassion. In fact, perhaps the most striking, a University of Washington study from years back, funded by the NIH, which found that in end-of-life conversations in the ICU, fully 1/3 of end-of-life conversations have zero expressions of compassion from the care team to the patients and families, and that's at the end of life. So rather than a specific story or anecdote, I just like to look at the data, and I think that the data line up with the data the last time that we talked, that a compassion crisis is here. The question is, what do we do about it?
Yeah. Well, and to that point, what do you see as the drivers of that? First, we'll just talk about maybe the general public, if you want to comment on that, and then, specifically in healthcare.
Well, I'll stay in my lane as it relates to healthcare rather than society broadly.
Yeah.
But there have been many drivers, I believe. One of the things that drives this, and this has been true for many, many years, but the hidden curriculum in medical education is a major driver of this. There's this, and I'm thinking about this because I just had the opportunity to be on the platform as our 120 or so medical students. These are newly minted doctors, walked the stage yesterday to get their diplomas, graduating from Cooper Medical School of Rowan University. And I think, what is it that we've taught them? Not overtly necessarily in the curriculum, because we know what that curriculum needs to be, but what have we taught them about the importance of compassion, the importance of not just caring for others like patients and families, but each other in a very stressful healthcare environment? And so this has been front of mind for me lately. I think that the hidden curriculum in medical education is a major driver of cynicism. And that's what I think, that's the word that comes to my mind when I think about the hidden curriculum. And so, of course, that hidden curriculum means things that are passed down to generations of learners in academic health settings that you won't find in any papers or any books or book chapters or anywhere else like that in the overt curriculum. But we have historically taught them a cynicism that typically creeps in by the third year of medical school. And the major reason why I want to, if it's one thing, hopefully I've got 20 years left in the tank. If there's one thing that I can do in that 20 years, it is to work to get rid of the hidden curriculum, not because it's the right thing to do, but because the hidden curriculum is not evidence-based. Cynicism is not evidence-based. I just think that that hidden curriculum, which is grounded in things that aren't really supported by the available evidence, it has been a major driver.
Yeah, we teach mostly by modeling, right? So
That's
that
right.
means that they're learning behaviors from faculty and other folks around them. And it's interesting that you picked out the word cynicism, because that's one of the key components that is measured in the MASLAC burnout inventory. So
That's
are we
right.
also sort of teaching burnout somehow?
Well, I don't know. I'm not an expert in burnout research, so I don't know if the cynicism part is a cause or an effect, but they definitely are associated. They run in the same direction, so to speak. So I do believe that historically, if it's one thing that learners have picked up in the hidden curriculum, it is this cynicism. And we could talk for a long time about how cynicism is not evidence-based, but if you follow the evidence, compassion makes measurable, not just meaningful, but measurable differences for patients and for patient care and for those who care for patients. And that's also, so that's for us too, the healthcare providers, that when you have compassion for patients and you get the meaningful relationships that flow from that, the deeper relationships, then you get the good part of what it means, whether you're a nurse, a physician, a therapist, a technician, any role in the environment. When you get the relationships that flow from that, you get the benefits of caring for patients. And if you don't have that, then you just have a really stressful job, a job that's really far more stressful than most careers you could go into. And it is the restorative power of those relationships that are therapeutic, even for those who care for patients, not just the patients who are on the receiving end.
Right. We'll get into that because I want you to talk about that some more. But in Compassionomics, you summarize this huge body of evidence about how compassion drives outcomes. Now, I don't know if you want to sort of, not you have to summarize the whole thing, but of all the studies that you've reviewed, was there one that really stood out for you as being particularly important or influential?
So Dr. Maz, that's Anthony Mazzarelli, my colleague and co-author. He's a practicing physician. He's co-president and CEO of my organization. And we did a quasi-systematic review and qualitative meta-analysis going through 1,000 scientific abstracts. Over 250 original science research papers are cited in Compassionomics, because we wanted to bring the same level of rigor to what people typically put in the emotional, sentimental, or moral, ethical domains, and test the hypothesis that compassion matters for patients, for patient care, and for those who care for patients. So we uncovered all this evidence, and it wasn't that no one was aware of these studies. When these studies were published, and we reviewed decades of data, these papers, they made a ripple or a splash. Mm-hmm. But what we wanted to do was push them all together to make a wave, a wave that hopefully is compelling to the reader, that compassion matters in ways that are not just a nice to have, like cherry on top of the sundae. That compassion is integral to good health and healing. And we believe that there is compelling evidence for that. So that's why we did the work. As far as one paper that sticks out in my mind, this paper has been on my mind today. So it was from 1995, and it was published in The Lancet. So, one of the 3 highest impact biomedical journals in the world. And it was an experimental trial. So a randomized control trial. It was at University of Toronto, and it was conducted in the emergency department. And it tested and the reason why I'm thinking about this is because we're talking about cynicism. It is probably the most cynical hypothesis I've ever seen in the scientific literature. They were testing the hypothesis that among a population of patients who are experiencing homelessness, that if you treated them with more compassion, they're just more likely to come back more. And again, this is not my hypothesis, this cynicism, okay? This is just what they tested. The thinking apparently was that if we treat them well, they'll just come back unnecessarily. That was literally the hypothesis they tested. I know that sounds incredibly cynical to people, but it was an experimental design. And so what they did is they randomized patients who were experiencing homelessness, who already had frequent visits to the emergency department. They had a way of defining that. And they randomized them to either usual care in the emergency department or more compassion. And as I understand it, although it's not super explicit from the methodology, I believe it was these were medical students. And of course, the medical students were new. They didn't really know, no disrespect to med students, but they were beginning med students. They didn't really know how to treat the patients, but they taught them how to take care of them, because there's a difference. And we say this all the time in my department of medicine in Cooper. I tell the learners when they show up as interns, we're going to teach you how to treat patients, and we're going to teach you how to take care of patients. So they taught these med students how to take care of patients and to show them extra compassion. And what they found was striking, because there was, in this experimental design, a statistically significant difference in the return visits to the emergency department. But it was exactly the opposite of what they hypothesized. Yeah. So the patients who were treated with more compassion actually came back less, not more. And the authors had to try to give some sort of an account for why that might be. And they just hypothesized at that time, maybe the patients just got what they needed. So I think about this a lot. It's a cynical hypothesis, but the results are absolutely striking.
It's so interesting. I wanted to just drill down just a little bit because I think I wondered if you could share your definition of compassion, because then it'll help us understand the literature you reviewed.
Sure. So I recognize that this is a hotly debated question in many scientific conferences.
Yeah.
And so what we found, Dr. Maz and I, when we went through the literature, is we found that most, not all, of course, because there's heterogeneity in the definitions that people use, most researchers defined it this way, that compassion is an emotional response to another person's pain or suffering involving an authentic desire to help.
Mm-hmm.
So it's different, distinctly different from a very closely related word, and that's empathy. So most researchers define empathy as the sensing, detecting, feeling, and understanding component, but that compassion goes beyond empathy to take responsive action in some way that could alleviate a person's pain or suffering to whatever extent is possible. So the way I like to think of it, because this is just an easy way to remember it, and it was actually this phrasing was coined by Dr. Don Berwick years ago in a conversation with Maz and I, but it's empathy plus action equals compassion. Empathy plus action equals compassion. Now, empathy is vital, of course, because if you don't sense, detect, feel, or understand another person's pain or suffering, you'll miss 100% of your opportunities to respond to another person with compassion. So, of course, empathy is vital, but compassion involves taking action. And one important point, Beth, that I need to make is that these are not just semantics, because there are robust neuroscience data to support the distinction in terms. So using a brain imaging modality called functional MRI that can show us what part of the brain is activated at any given moment in time, that research shows that when we bear witness to pain or suffering, it activates the pain center in our brain. It lights up on the scans. And we all know this experientially because it's very uncomfortable to watch people suffer. We know that experientially, but what the same research modality shows is that when our minds are focused on helping, serving, alleviating, taking away a person's pain or suffering to whatever extent is possible, a distinct neural structure is activated. And it's not what neuroscience researchers consider a pain center of the brain. It's what they consider to be a reward center of the brain. So associated with positive affect, positive emotion, feelings of affiliation. But you know that experientially as well. We all do, because that's part of the reason, not all of it, but part of the reason why it feels good to help people.
Absolutely. And that's the point you make in your second book, which, we will certainly get to. I mean, I think your definition actually is really helpful. And I think you meant too that if you're going to review literature, there has to be some documentation that a behavior was engaged in, right? Not just sort of the sensed response, but something observable and measurable. Am I right in saying that?
I think so. And obviously, I definitely welcome your opinion as you're an expert in this, of course. My thinking is that it's not what we think in our mind or feel in our heart necessarily that a patient can experience. It's how we behave towards another person. So for example, my team and Dr. Brian Roberts, who's our science director, he helped me to design a study, which is now funded by the AHRQ, ARC, it's a mixed method study, both semi-quantitative and qualitative. But what we're trying to test is what are the specific behaviors that are actually most closely associated with the patient's experience of compassion, with the understanding that it may be different for different populations. For me, it may be the set of behaviors that are integral may be different from a person who is from Camden, New Jersey, which is a very special place, but with very serious challenges, and somebody with significant life trauma who's grown up here may have the behaviors may be different than they are for me. And so our research is trying to, because we want to be actionable, right? So we want to be able to teach learners what are the specific behaviors that are most closely associated with a patient's experience of compassion or not. And to your point, it's the behaviors. It's the outward behaviors, how we behave towards other people.
Is your idea then to translate this into curricula? Because I know you said your one thing that you want to get done in your next 20 years is to really change how we teach and model compassion.
Well, we actually see it as an opportunity for studies with experimental designs, trials of specific behaviors. And so what I'm about to say, I say with all due respect to colleagues of ours, anybody who's watching from all the different professional societies, professional schools across the country. What we've typically done, and I say this, like we do this at my medical school as well, for the doctoring course for learners, right? We take a physician who is known, he or she is known for, their patients love them. And and perhaps they're not just senior, but even maybe winding down a career because that's how much experience they have in dealing with patients. And we ask them to teach our learners, here's how I've done it in my experience. This is how, right? And it's like the apprenticeship model.
Yes.
And we learned long ago that that's not the way to teach medicine to learners, right? It's not the apprenticeship model. Rather, we need to rely on evidence-based medicine. We need evidence rather than just apprenticeship. And similarly, I think that we can, if we're rigorous enough about it, generate an evidence base that will inform that teaching. So rather than just anecdotes or mentoring, it can be, I would love to be able to tell my students that here are the top 3 behaviors that have the highest odds ratio for patient experience of compassion, and teach it in an evidence-based way. There are a lot of people who don't share the opinion I just shared with you, but that's just my opinion.
Yeah, no, but it's important. So there are 3 things that just popped right into my mind. So early on, I was really involved with teaching communication skills to students and, practicing faculty, residents, and so forth. And there are lots of frameworks for communication out there that have been taught. Until recently, they were, the National Board of Medical Examiners was trying to assess these, and step 2, that was done away with in the pandemic. And there was a lot of resistance and backlash to that step anyway. But a couple of things come up. So one is teaching who you are is really different from teaching specific communication skills.
That's right.
It's who you are and what you bring to an interaction and a relationship. And your sort of your open, loving stance towards a person, that matters. There is the communication skills, and that's a teachable, learnable thing. Those are skills that can be taught and learned. And then there's something you just brought up, which is the whole aspect of culture and, cultural humility, so that it's not going to be one size fits all. And this came up when we started trying, years ago, decades ago now, people started trying to teach what they were calling cultural competence. And then, really we soon realized that that's maybe a misnomer, because everybody is so different. No one person represents the entirety of the culture. So your desire to sort of teach this is going to, I'm sure, be multi-pronged and really complex. I don't know if you have any thoughts about that. I mean, those are only just 3 things that just, blasted into my mind in terms of how do we actually do this?
And you said something really important that I didn't say, and I should have. You mentioned, and I'm paraphrasing what you said, but it has to be congruent. The behaviors have to be congruent with who you are.
Yes, authenticity, right?
Because if you're just learning a specific behavior that may have the highest odds, but people know, I mean, patients can detect 100% of the time a lack of authenticity.
Yes.
And so it has to be congruent with, and you said it much more eloquently than I could, but it has to be congruent with who you are, or it will not have its intended effect.
Yeah, for sure. that's a whole other issue. Because honestly, I feel like, and you know this from the neuroscience, I don't think we have to teach compassion. It's hardwired in our brains. The question is what's preventing it from emerging, you know, in these, you know, authentic interactions with patients. And, you know, how can we help people be open and willing to engage in a really meaningful way?
Well, I also have to also acknowledge one of the things that we didn't talk about at the beginning is I'm an intensivist. So I'm a specialist in intensive care medicine. A huge proportion of my patients are in a coma, essentially, right?
Yeah.
But I can talk with the patients' families. So sometimes I'm jealous of my colleagues that are in primary care and other specialties because they get a richness of relationship that I don't always get with my patients who are on large doses of sedatives. But I have learned more from my colleagues that have whose patients love them in the ambulatory setting than they've taught me a lot. That's for sure.
Yeah.
And I am one thing I have to say, because I usually say this at the outset of a conversation. I personally am very much a work in progress, 100%, 100%. The important thing is that I see it now, and I'm aware of the evidence that we can in fact get better. And so I didn't believe that. And so this is, I think, super important for some folks because when we started, Dr. Maz and I started this work, I thought people were either wired for compassion or they're not. Like it's something in the fabric of who they are. It's in their DNA. And to be fair, there are some elements that may be rooted down deep in, for example, your DNA, but most researchers think it's only about a third of one's propensity or capability, I should say, which means that 2/3 of it, a majority, is not.
Yeah.
And so the evidence points to changes possible, not in a like pithy bumper sticker kind of way, but in a real way. Like if you work at compassion and human connection, whether it's with your patients and their families or your colleagues or anybody, what the research supports in total is that we can in fact get better, but we have to work at it just like we work on anything else.
Yeah, well, I 100%, you know, agree with you about being a work in progress, and thank you for saying that. It shows your humility. But you also mentioned something really important, and that's self-awareness. You know, there's something really important about also learning the skill of metacognition and, you know, sort of being able to be aware while you're in a conversation of like, what am I experiencing right now? What is that person saying? How's it affecting me? How is what I'm saying affecting that person? And that's actually a really interesting part of engaging with patients, you know, especially in the outpatient setting, with certainly in the old-timey, you know, primary care doc from way back. But that was, I think, the most wonderful and glorious and enlightening and such a great learning space to be in once you learn how to do that. It's just a joy. It makes every conversation incredibly meaningful.
Can I share something that raised my self-awareness, or I should say, made me aware of where sometimes I was falling short? So I always thought, and I'm just being honest, I always thought I was really good at family meetings. Okay? That's what I thought.
Yeah.
And then I became aware of a study from the University of Colorado, and it was conducted in the emergency department. And they enrolled patients who checked in with the triage nurse, and then they recorded the chief complaint. And then the research part of it was they asked the patients, what worries you the most? What worries you the most? And then they measured, and they had a way to look at inter-observer agreement and all this. What was the concordance or discordance between what the answer to the question, what worries them the most, and their chief complaint? And so, for example, a patient had a chief complaint of chest pain. What worries him the most is that he knew that he was back in the emergency department because of the drugs, and that if he didn't get better from this, who's maybe going to lose his family.
Mm, mm.
So I'm sure that the emergency department team was doing EKGs, doing cardiac biomarkers, doing all the things that are standard of care for a middle-aged person with a chief complaint of chest pain. And those things ought to be done. But if you don't know that what worries the patient most was actually addiction,
Yeah, sure.
how are you going to take good care of them? And the reason why I'm telling you this story is that I used to think that I was really good with families. And I'm not saying I'm not, but I still like to think I do okay. But I'd have a family meeting ever since I read this paper. And then when I'm done, or what I think, okay, we're done now, I'll ask one more question. What worries you the most? And Beth, I am blown away by what comes out of people's mouth.
Yeah.
I mean, what is front of mind for people? Like things I never would have thought of. And sometimes there are things I can help with. And then sometimes they're not, and that's okay. Like we can't always worry about being a fixer. Like if we ask a question, they tell us something, we can't fix it, then, we're uncomfortable. I know doctors especially love to be fixers, but a retired pastor who used to make a lot of hospital calls in my ICU before he retired used to say, "What's wrong with you doctors? Like, why are you guys so uncomfortable with silence?" Like he used to teach about the power of presence, like just be present for people in that moment, and just being present and letting people know that they're not going to go through it alone says more than you could ever say with words that are coming out of your mouth.
Yeah.
So if it's one thing, like if there's any trainees or early career folks or anybody on the meeting today, I mean, if it's one thing I've learned, and this is evidence-based because it comes from a published research study, I just ask people at the end, and I do it at the end because I want to detect if I actually thought we were done or not. And it turns out that a lot of times I find out that I hadn't even really scratched the surface of what was front of mind for them. But I asked the question, what worries you the most? And it's changed my practice for sure.
That's so fantastic. We should really change the first heading, from what's the chief complaint to what's the chief concern. Teach people to really be thinking about that. It's not so.
I like it.
This is also part of, trauma-informed facilitation, teaching, and care. It's transitioning from what's the matter with you to what happened to you, and tell me more about it,
And it also underscores why patient experience and I know that terminology means different things to different people, but I just recently have started geeking out on the neuroscience of how we make memories.
Oh yeah.
So I'll share with you, I think I shared with you the last time we were together, but so there was this study from like 2015. There was this bus crash in Sweden that literally sheared a bus in half.
Yeah.
And somehow there were about 50 people that survived, that were saved. And then they asked people 5 years later, 5 years, not the next day, but 5 years later, what did these survivors remember? And what they found is that they don't remember the kind of external fixator they had on their lower leg fracture. And they don't remember what kind of IV medication was running through their IVs. What they remember is how they were made to feel in the moment, because there's something about healthcare experiences that stay with people. And I'm not a neurologist. I do have some background in neuro ICU, but I don't know if it's because the hippocampus and the amygdala, where we experience our intense emotions, is so close together. But where there's as I understand it, where there's intense emotion, that's how we make our memories. And so I don't know. Sometimes discouraged isn't the right word, but I think that we're a little bit off. Like, how can what people remember 5 years later not be an important outcome measure? I know it's hard to measure, right? But if we really want to talk about what's lasting for people, I mean, there's something about healthcare experiences that stay with people.
They're highly salient. Yeah. Yeah, that's so interesting. Well, I'm pretty sure you put that vignette in Compassionomics, because I remember reading it in there, Steve.
Well, actually,
That's
I'll tell you, so I've been working in the ICU for 25 years in total, 22 years here at Cooper as an intensivist. I'll tell you can I tell you really quick what my
Yeah,
most salient memory is from
yeah, yeah,
22
yeah,
years?
yeah.
And we share this actually in Wonder Drug. That's our second book. But so I was having a family meeting, and it was because there was like a 55-year-old man who's admitted with septic shock. So so this is overwhelming infection. The organ systems are shutting down. I could tell just based on experience, he was not going to make it through the night.
Mhm.
No way. And so that was a really hard talk I had to have with his sister, who was just a couple years younger. And it was especially hard because he had been her, as she said, he'd been my rock, throughout my whole life. And so we had our conversation. And at that point, I hadn't learned the lesson of asking the question, what worries you the most?
Mm.
And so I thought we were done. And then she said, or she asked me a question I'd never been asked before. She said, you don't remember me, do you? And I said, I'm sorry. She said, it's okay. I would not expect you to. You guys take care of so many patients in here. You're so busy. I wouldn't expect you to remember me, but I need you to know something.
Yeah.
And she takes her hand and she points it at the bed, literally exactly across the hall from the bed where her brother now laid. And she says, 7 years ago, my mom was in that bed right over there.
Yeah.
And she was dying.
Yeah.
And there was nothing that could be done to save her. And you were her doctor.
Oh my gosh.
And you had to tell me that. So you and we've had this talk before.
Oh God.
And it took my breath away, literally. Like when I think about it now, it still takes my breath away. But what she said next, not only will I never forget, I teach every trainee I can get my hands on this principle. What she said, and this just goes back to the principle, like there's something about healthcare experiences that stay with people, and perhaps it's the emotion that's involved. But she said, I need you to know this. Those nurses, she said, they were like angels to me.
Mhm.
And she said, they held me in those days when mom was dying, and they let me know I wasn't going to go through it alone. And I didn't because of them. So what I want you to know, this is what this is why she was telling me this. She said, what I want you to know is every time I think about losing my mom, and it hurts so much even now because my mom and I were so close, I think about it every day. What I want you to know is every time I think about losing my mom, I think about those nurses, and it makes me feel better even now.
Yeah. I'm gonna start start crying.
7 years later.
Yeah, for sure.
So, what do we want to be? What I tell trainees, fellows, med students, residents, like, what do you want to be remembered for? But
Yes.
when you know that that's your power, like when you meet somebody in that moment, and by the way, I need to say this, like ICU nurses, they're like, or all nurses, I believe, but they're like Olympic champions in compassion, right? So
Yes.
they probably were like, this is just what we do. This is who we are, and they went home at the end of their shift, and maybe they didn't even think much of it, or 2 weeks later, maybe they would, a month later, maybe they wouldn't even remember it because it's just who they are. But she not only remembered it, it was therapeutic to her 7 years later.
Yeah. Yeah.
So when you know your power in that moment of like because what people say, and that was both a loss for her, but a good thing, meaning that she remembered the compassion of the nurses. But we Dr. Maz tells a story in Compassionomics about a loss that he had in his family, and these things just echo and reverberate and go on, never to be forgotten. So it can echo and reverberate in two different directions, right? And so when you think about that power, though, it makes, at least for me, it makes me feel differently about those opportunities.
Mm, mm.
Anyway.
Yeah, no, you know what? I mean, and what comes up for me too is Ken Schwartz's words, that these small acts of kindness, these exquisite moments of compassion are
Mhm.
for him what made the unbearable bearable.
That's actually my favorite quote
Yeah,
from Ken Schwartz's work. I never had the opportunity to meet him before he passed, but that's what the Schwartz Center is all about. We think about the Schwartz rounds in the hospital, and we've had some amazing Schwartz rounds that have been really impactful for us. That's what it's grounded in.
mhm, yeah,
And so he framed it maybe in a little bit different words, but that's exactly can't say it better than he said it back then.
yeah, I know, I know. I want to take a little time now just to transition a little bit about been talking a lot about the impact of compassion on patients and families and a little bit about its impact on us. And I'd like to just hear you talk a little bit more about that. That's, represented in your book about the wonder drug. Because you have some really practical ideas in there. And I wonder if you can share some of that stuff. So, there's something you call the 16-minute prescription. You want to describe that a little bit, and then I'm going to ask you about 7 steps to take now.
So I'll start. What you first pointed to is, the effects for ourselves.
Yeah.
And so it's where the science meets the personal for me. So if you would have met me 10 years ago, you probably would have met a pretty different person. So I went through burnout myself. This was after like 15 plus years of working in the ICU. And as you know, we often meet patients and their families on the worst day of their life. And I became aware that I had every symptom of burnout myself, and I'll just leave it at that. I'll just say, that's not a good place to be. So that's when Dr. Maz and I were doing our work on compassionomics, and I saw the evidence that compassion can be a powerful, beneficial therapy for the giver too. Now, when I was in medical school, I remember being taught, literally taught, and maybe you were too. I was taught this: don't care too much.
Yes, equanimity, right?
Yeah, but you know what? If you go back to Osler's
Yeah,
writings,
yeah.
and this is how much of a nerd I am. Like last night I was reading. Anyway, we I won't go down that rabbit hole,
Yeah, yeah,
but
yeah, yeah, yeah.
it's uh I was taught don't care too much because too much caring, too much compassion burns you out. So I didn't think to challenge that dogma for 25 years until I was in the throes of burnout myself. And what was I supposed to do? So the conventional thinking was like, get away more, like take more vacations, do hot yoga, take a nature walk by yourself and, put on your headphones and block out the world. And I just wasn't buying it. Like I thought something. First of all, that's not sustainable. To just as if you just get away from your patients as much as possible and everything will be fine. Like I don't. It didn't compute for me.
Right.
So I thought something had to fundamentally change at the point of care, and that's when Dr. Maz and I became aware of the data that compassion can have a powerful beneficial therapy, be a powerful beneficial therapy for the giver too, because in contrast, stark contrast to what I learned in medical school, imagine now it was like 2017 and I went to the data because that's how much of a nerd I am. I like literally went to PubMed because I'm a research guy. And where anecdote and opinion and stories once reigned, this whole don't care too much because too much compassion will burn you out. Now there were actual research studies. And imagine my surprise when 80% of the research studies showed that compassion and burnout were associated, strongly associated,
Yeah,
but it's inverse.
yeah, exactly.
So if what I was taught in medical school is true, it'd be high compassion, high burnout, low compassion, low burnout. But what the research actually supports, 80% of the published studies is high compassion, low burnout, low compassion, high burnout. So why? Well, if it's one thing that we found in our work in both of our projects, it's that the key to resilience is relationships.
Hmm, hmm.
So I decided I was going to lean in rather than pulling back and detaching and escaping, and I was going to care more, not less. And I don't mean just with patients and families in the ICU or the nurses that I'd worked with for 15 years at that point, but with my trainees, with my colleagues, and even at home. And I got the deeper relationships that flowed from that. And that's when the fog of burnout began to lift for me.
Yeah.
So we shared that experience, but also all the data, which I think is really what people find compelling, curating all the studies. And then we would get Dr. Maz and I got these messages, we'd get emails from far and wide, healthcare providers we've never met before, nurses, physicians, a couple technicians, like people would just say, look, I was in the same place and I tried it and I got the same results. So that's when we got to thinking there must be, it can't just be a phenomenon for people who put on scrubs every day and go to work in a hospital. Like there's got to be a common thread or a universal perhaps. And that's when we started doing our work for our second book, which is called
Yeah.
Wonder Drug, which is basically rather than for the healthcare community, it's for everybody everywhere. And it's the most salient scientific evidence that serving others can be the best medicine for yourself.
Yes.
And if you lean into that in a meaningful way, not just like, in a give to get reciprocity, because what the research shows is that motives matter. But that you can the personal benefits as an unintended consequence or side effect of a life focused on serving others, and it has to be like a life, like you have to make it like part of who you are, because it's not just a one and done, like, oh, I helped an old lady across the street, I'm going to live to 95, right? It's like, that'd be like, oh, I ate my spinach one time, I think I'm going to live to 95. Of course, that's not how it works. So it has to be like part of who you are and the fabric of who you are. And so anyway, we just curated all that evidence. And so, that's how the second work came to be.
That's wonderful. I was also going to mention there's this long running study. It was started in 1938. It's called the Grant Study with Harvard undergrads that they follow forever, forever, forever. And after those many years, the current director of that study said, well, we can summarize this in I think it's 5 words or something. The key to longevity and health is love, full stop. Love and meaningful relationships.
Yeah. So the Harvard, Grant was the benefactor, so they called it the Grant cohort, but it was the Harvard study of adult development.
Development, right. And,
they're on their 4th study director, and it just shows the power of human connection impacting health and well-being. So
yeah. There's some wonderful comments in the chat, and I want to make sure we can get to some of the questions too in the Q&A, and I hate to do this because it's really fun to talk. But let me get to the Q&A first.
Sure.
So one is, does data exist to show that certain physician reimbursement models demonstrate more or less compassion?
So I am not aware of any data on reimbursement models and more compassion. I could generate some hypotheses, but no, I'm not aware of any data on that. What I am aware of is that there are, because the questioner brought up payments. So there's also evidence that more compassion is also good for the bottom line.
Yeah.
So this is true not only in patient experience, whereas good patient experience drives business, but even just in like, for example, medical malpractice is a very small, like if we eliminated, it's just not a huge proportion of the cost crisis that we have right now.
Yeah.
But the evidence is quite clear, and I tell my residents this all the time, the reason to treat people the way that they ought to be treated is not for medical malpractice, but if you do that, an unintended side effect is that you might not be sued, because there is tons of data, and we go through this in Compassionomics, that there is anyway, I won't go down that rabbit hole, but it's good for the bottom line as well.
Yes, and less risk incurred from malpractice suits. Is it possible to act with compassion with sympathy rather than empathy?
Yeah, that's a word I don't. I see sympathy defined many, many different ways, just like compassion. So I'm not really sure I don't have a good working definition in my mind. So I usually just stick to empathy and compassion.
Yeah, yeah, right. This is a question that I'm sure everybody's wondering about. What's the response to the complaint that caregivers already don't have enough time to do their jobs without more expectations being added?
Yeah. So the most striking piece of data that we found in our work so far, in my opinion, has been the number 56. So according to a study published in the Journal of General Internal Medicine, 56% of physicians said that they don't have time to treat patients with compassion. Pretty striking, I think.
Yeah,
56. But it begs the question, like, how much time does it actually take? And so researchers from Johns Hopkins University wanted to test that. And they did it in experimental design among over 200 patients, the majority of whom were survivors of breast cancer. They randomized them to an information-only consultation with an oncologist versus an enhanced compassion intervention. And the primary outcome measure was anxiety, measured with a very well-validated scale. And if you've ever had cancer or somebody close to you has had cancer, you know anxiety is a pretty important outcome measure. So what they found is that enhanced compassion not only had a meaningful, but a measurable reduction in patients' anxiety. So then the question is, well, what's the intervention? And so it was actually things like, I know this is a tough experience for you to go through, and I want you to know I'm here with you. The things you say that I say to you today may be difficult to understand. I want you to feel comfortable in stopping me if something is confusing or doesn't make sense. We're here together and we'll go through this together.
Yeah.
And I'll be with you every step along the way. So how long did that take?
Yeah, exactly.
Well, they measured it and I was speaking quickly and it was 40 seconds. So if we're going to be evidence-based about it, rather than just saying, I don't have time for compassion, which is not evidence-based. If anybody wants to square off on that, I'm ready because I've got the receipts. Okay. If we're going to be evidence-based about it, a 40-second compassion communication can make not just a meaningful, but a measurable difference in a person's anxiety level in patients who are survivors of cancer. And so, and now that might lead into another communication. We also review the data that show that in total, it is rarely over 5 minutes. And so, I actually think that this is a mindset thing. So we think being compassionate towards other people takes so much time, but actually when you measure it, it doesn't. So like, for example, there's a University of Pennsylvania study which randomized people to 4 different uses of time. And they wanted to know what was the impact on what they call time affluence, the feeling like they had plenty of time and they weren't in a hurry. So what were the 4 things? Wasting time, spending time on yourself, getting an unexpected windfall of free time, or the last one was spending time helping other people. And they found that only one of those uses of time actually increased a person's feeling of time affluence, the feeling that they have plenty of time. It was spending money on other people. So there's something about spending money or spending time helping other people that makes us feel different about the time that we have. So one of my colleagues used to say, you can go through your day with brusque efficiency, letting everybody know exactly how busy you are or how busy you think you are. But if somebody held a stopwatch to you, you would find out quickly that that is just not true.
Yeah, that's so interesting. You know, we used to
and I need to say, Beth, like I work in the busiest critical care center in Southern New Jersey. Okay.
Yep.
I know that I'm not in the chairman's office 24/7. Okay. I practice a substantial amount and I know what it feels like to be really busy.
Yeah, for sure.
But if we're being evidence-based about it, it's more in our head than in reality that we don't have time to treat people with compassion.
It's so interesting, isn't it? We used to teach, communication nerd here, RSVP, show respect, reflect back what you've heard, offer
Yeah.
support, validate people's feelings and emotions, and provide a sense of partnership. I'll be here with you. It's a
Mhm.
nice way of remembering all of that.
Yeah.
So let me go back to here. We have just a few minutes left. That's a great answer to the time issue. Do you see any difference in the cognitive awareness around compassion, the importance of compassion in healthcare providers from different professions? And if so, to what do you attribute that?
Different medical, well, so like I said earlier, I think nurses are Olympic champions in compassion, and my measuring stick, if you will, is the nurses. So when I come out of a family meeting, I'll ask the nurses, and some of them I've worked with for literally, 22 years, how'd I do in there? And they are not shy. They will tell me, right? They'll say, oh, you did really nice, or you know what, it wasn't your best work. But like I said, I've learned that I'm a work in progress, so always trying to get better. So I don't really discern between different physician practices, but I think a lot of our anyway, I'll leave it at that.
Well, I have to tell you, you probably aren't seeing this, but the nurses are really giving you shout outs in the chat. Thank you. This is the best tribute during Nurses Week I've ever had. And,
Oh, it's very kind.
just wonderful. Your story warms my heart and soul being a nurse. Okay. Here's another question. You've asked what worries most at the end of a family meeting. What if you shifted this to the beginning? And have you done that? And if so, how did it change the family meeting experience? It's a good question.
I love the question. I should do that. The reason why I don't is because I'm using it to try to detect how good of a job I did in the front part. Because that's how I would have normally conducted a family meeting. And so I find it to be more striking if I bring it in at the end, because it shows me my limitations in understanding. Like, I thought we really connected, but obviously I didn't if I missed their main concern. Do you know what I mean?
Yeah, it's like your final exam there, right?
Yeah, right.
Let's see, how have things shifted after COVID-19? What's the data? I'm not sure exactly about where can we find the data, and is it post-pandemic? But I'm not sure what it is referring to exactly. Has things shifted after COVID?
I think that if it's one thing, and I have to say this out of respect for everybody that we lost, that there's nothing good that came from the pandemic.
Right.
And that being said, there's something that something called elevation. So that's this concept that Jonathan Haidt and others have done a lot of research on this. But elevation is that feeling of emotional uplift that you feel when you bear witness to another person's moral excellence or heroism. And there's nothing good that came from the pandemic, but there are a lot of things I'll never forget. And it's the heroism of other people. And I don't just mean the people that work in the hospital in the ICU, but like neighbors who are taking groceries to the elderly person around the corner who was scared to go outside. I mean, I know we often talk about the pandemic as something that damaged us, and it did. I wouldn't ever suggest that it didn't. I think we've all been affected by it, but at the same time, it also there were moments in there where I saw like the best of people. And what research shows collectively, and we talk about this in Wonder Drug, is when you are elevated by other people, it makes you want to raise your game yourself. It makes you want to be better than you are when you, and that's why I spend a lot of my time in recruitment, because my major question is this person going to raise us up or drag us down?
That's such a great point. Julie's coming back on. That means we have to wrap up, I'm afraid.
Thanks so much. It's been a fun, it's always a fun chat.
So much fun. Thank you so much, Steve. And it's just so great, to hear you talking about this stuff. It's like, makes me feel really excited, inspired, uplifted. So Julie, turning it over to you.
Thank you,
Oh,
Beth.
Julie, you're muted, Julie.
Sorry about that. Thank you so much to Dr. Trzeciak. That was an incredible conversation. And thank you to all of you who joined us here today. We hope you enjoyed this Compassion in Action webinar. Please keep an eye on your email for news of future events. And finally, please take a moment to fill out the very brief survey we'll be sending you after the webinar. We really do appreciate your feedback on today's session. Thank you for joining us and for your commitment to compassionate healthcare. Take care, and we hope to see you soon.
Thanks again. Bye, everyone. Thanks, Steve.